Next session for today, which is on tumor necrosis with Dr. Corbin and Dr. Donovan. Dr. Donovan's already had her introduction this morning, but I'll do a brief introduction for Dr. Corbin and then we'll get right back into it. So Dr. Emily Corbin received her bachelor's degree from Stanford University and her DVM from Texas A&M University. She joined the Army and served as a clinician and public health veterinarian for 6 years prior to starting her residency at the Joint Pathology Center. Upon finishing her residency and becoming board certified, she has served and currently serves as a training officer at the Joint Pathology Center. She has 2 children, enjoys diagnostic pathology and outdoor activities, and looks forward to in-person meetings. I'd like to welcome Dr. Emily Corbin and Dr. Taryn Donovan with tumor necrosis.
All right, thanks, Lauren. So good afternoon, I'm Emily Corbin, and as Lauren said, I'm currently serving as the training officer at the Joint Pathology Center. Thanks so much for joining me and us as we move on to our next topic in the veterinary cancer guidelines and protocols discussion today. Taryn Donovan and I will be talking about tumor necrosis. So we'll be discussing the issues and topics brought forth in this article, as well as in supplemental file 5, which is found on the VC GP website and is already in the process of being updated. So thanks to these authors, and thanks especially to Bruce Williams for trusting me to articulate his words here to the group today. The main points that Lauren and I were going to discuss is we're going to touch on why we evaluate necrosis in tumors to begin with. We'll talk about how we currently have a lack of standards for assessing necrosis. We'll briefly glance over gross versus microscopic assessment of necrosis. We'll talk about how we need to standardize trimming and the group's suggested method to start heading towards that direction. And then we'll broach the subject of why necrosis may not always be appropriate or ideal in a grading scheme. So first off, why bother looking at necrosis? So we use the humans as guinea pigs here. The human pathologists found that for human tumors, the extent of necrosis that they evaluated both grossly and microscopically correlates to tumor biological behavior. And therefore it was included in many tumor schemes. So this correlation with tumor biological behavior makes sense because the greater the amount of necrosis, the more aggressive the tumor is, and the more quickly it's outgrowing its blood supply. A quick literature search on my part pulled up these human grading schemes listed here, which all include necrosis as a factor. And since it worked so well for humans, we extrapolated the use to veterinary pathology. We typically use histo only and not gross estimate of necrosis. So we'll start with soft tissue tumors or soft tissue sarcomas. We'll use those two interchangeably throughout the talk and on our website.
Emily, we seem to have lost you. Are you still there?
It looks like, not sure if she's there.
Yeah, we lost her connection.
Yeah. We might have lost the connection.
Let me see if I can contact her.
Thanks, Rafa. Welcome back.
Sorry about that. Is everyone there?
Yes.
Yes, we can
Okay,
hear
where
you.
was I when everything dropped out?
Ooh, not sure.
You were on slide 4, going to slide 5.
Okay.
Corbin, from now on, if you would like to keep your camera off, it might improve a little bit the internet.
Okay,
Thank you.
thanks.
Somebody wrote in the chat that you had just mentioned STT and STS is used interchangeably.
Perfect. Okay. 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 So we use them interchangeably throughout the talk. Then Trajani in 1984, he and his team did a study, and they found that of 7 of the features that they studied with soft tissue tumors in humans, 3 of the features correlated with patient survival. And those 3 are listed in mitotic count and presence of necrosis. And if you spend any time on diagnostic service, you'll recognize these 3 as the same features that we use in our canine soft tissue sarcoma grading scheme. So veterinary medicine borrowed this same exact grading scheme from the human medicine before we knew whether these parameters were prognostic in our veterinary patients. So here's a table that I put together based on information from the cited review paper down below that was just hit the press today. It was e-published online first before today. So this paper reviewed published histologic grading systems in veterinary medicine. And the authors had recommendations on whether to utilize the systems based on the relative level of validation and reproducibility. And then from all the systems, grading systems listed in that paper, I pulled out all of the ones that included necrosis as a parameter. And then over on the left, I bolded those systems that the authors recommended using. And you'll notice that only canine soft tissue sarcoma is bolded there. And then over on the right, I listed the necrosis cutoff values that the pathologist would need to identify to utilize that system. Moving on, before we talk about how to apply the amount of necrosis in a grading scheme, we should touch on what necrosis looks like. So this slide should make everyone feel a little bit more comfortable. This is our bread and butter. And especially as training officer at the Joint Pathology Center, where we pride ourselves on descriptions of our slides. These descriptions all roll right off my tongue. So coagulative necrosis characterized by retention of architecture with loss of differential staining. Lytic necrosis characterized by loss of architecture with replacement by cellular and karyorectic debris. And single cell necrosis or single cell death characterized by shrunken angular cells with hypereosinophilic cytoplasm and nuclear pycnosis, karyolysis, or karyorexis. I use the term single cell death here rather than necrosis or in addition to necrosis. Now that we know that there's so many other kinds of cell death, it doesn't seem like it is, it's single cell necrosis is a little bit too specific because we have all those other kinds of apoptosis and pyroptosis and ferroptosis and methoosis now. And it's a complex topic, and we at the Joint Pathology Center don't have all the necessary immunos to get to the bottom of it anyway, but that's a topic for another day. So to continue to make everyone feel good here, here's an example of coagulative necrosis. This particular one was a canine mammary intraductal papillary carcinoma. And notice there's retention of architecture. Here are all the cells with the stroma of the papillary carcinoma, but there's complete loss of differential staining. There's just pale eosinophilic outlines of cells, but no nuclei, no basophilic stain uptake. And here's an example of the lytic necrosis, or liquefactive necrosis. At the center of these neoplastic islands, there's loss of architecture and replacement by cellular and karyorectic debris. In this case, specifically, it's comedonecrosis. And then my last feel-good slide for you. At the center here is this an example of single necrosis or single cell death. This shrunk hypereosinophilic cytoplasm and a pycnotic nucleus. All right, and it's important to remember that necrosis tumors can result from other things, such as those listed here. In human medicine, necrosis is even used in some cases as a prognostic measure post-chemotherapy, post-radiation therapy. And then also note that surface ulceration should not be included in soft tissue sarcoma estimates of necrosis. And moving on to tumor sectioning. How does everyone out there do it? And how are you taught to do it? And how is your grossing technician taught to do it? And significantly, how was it done in those published grading scheme studies? Our grossing technicians, first off, do not currently provide any estimate of the amount of possible necrosis, unlike is done in human medicine. So is the gross necrosis estimate prognostically valuable? Well, we don't know. How good are we, or how good are our technicians at estimating gross necrosis? We also don't know that. Wouldn't it be nice to know? And then secondly, our grossing technicians are trained to avoid trimming in areas of necrosis because those are least diagnostic for us pathologists. But that introduces bias into the study, as well as into our everyday diagnostic service. So how do we expect to have reproducible, valid grading schemes when we knowingly introduce bias into our samples? So here's what the group proposes regarding standardization of tumor sectioning. You can find these recommendations and documents on the website. And these are screenshots from the document. So on the left is the tumor quote unquote signalment. So you want to record the tumor's location on the body and its size. And worth noting whether the size is gross or histologic measurements, since formalin fixation can result in shrinkage. And then that size should inform the number of sections that should be examined grossly and histologically. The group suggests starting with 1 section per 2 centimeters of tumor at its longest dimension. And then over here on the right displays the different tumor sectioning methods, which could be used depending on the size of the tumor. So for example, does it fit into a cassette? Then use the radial method. If it's bigger than that, consider using the parallel or bread loafing method. And if it's irregularly shaped, you could use some combination. And then here's the group's suggested way to estimate gross necrosis. They recommend recording who's making the assessment and then record the estimated amount of necrosis. And we used the soft tissue sarcoma grading system numbers because that seemed like it would be the most reliable and reproducible. We also recommend annotating how many sections were assessed to come up with that estimate. And then we recommend including if a necrosis estimate was based on any clinical imaging like MRI or CT, both of which have some specialized methods to differentiate between viable and necrotic tissue. At the JPC, we typically don't get advanced imaging along with our tumors, but some institutions are more likely to have that. And with that, I will pass the torch off to Taryn, who's going to discuss histologic estimates of necrosis.
All right, great. Thanks, Emily.
Mm-hmm.
All right. Okay, so I'm going to take it now with just talking about histologic estimation of necrosis. So even though this is something that we feel like we do all the time and we're good at, we really, when's the last time you read a description of how we're supposed to do this? It's really not, there's no established method of how we should be reporting percent necrosis in histologic sections. So, these are things that we could probably easily standardize by just writing detailed methods. So in terms of how we estimate necrosis, there are 2 main methods, and this is pretty simple when you break it down. We're estimating the amount of necrosis visually with low and high magnification with either light microscopy or whole slide images, or we're using annotation software. So we're outlining necrosis areas and then measuring the percentage, outlining necrosis and then outlining tumor area and then getting the percentage. So again, this estimate is usually reported as a percentage, meaning that, we're saying how much of the tumor area represented in the slide or a group of slides contains necrotic tissue. Now, we don't really have standards as far as how many sections should be estimated per tumor, and we really don't have a standard in terms of how we should be reporting it, meaning should we report the highest percent estimate of necrosis, or should we be reporting the average percent estimate of necrosis? And I bet if you asked 10 pathologists, you probably would get a lot of different answers in terms of how this is reported out. So these things certainly would depend on, how you normally think about them. And if they weren't spelled out, it might be a little bit hard to get standardization or replication of that. Cutoff values are going to depend on the grading scheme. So just like the chart Emily showed, depending on what grading scheme you're following, you might have to estimate 15%, 25%, or 50%. So now this is the chart coming from the guideline. And so we have more of a basic breakdown of 0 to 10, 10 to less than 50, and then greater than 50. And again, that's based on some of the soft tissue sarcoma grading scheme protocols. And that is because, that is pretty well established in terms of percent necrosis. But you might be asking yourself, why do we have 10% there? That seems a little weird. And Don mentioned this earlier, and that it's based on this reference right here. So this reference from Kuntz, 1997, looking at canine soft tissue tumor, dogs with greater than 10% necrosis were 2.8 times more likely to die of tumor-related causes. But we don't see that data reported in the manuscript. And so this would be something that we would want to validate with detailed methods. So, in terms of thinking about performing studies and detailing how you would talk about necrosis in the methods, some things to think about and to consider would be, writing down how your samples were selected. Did the technician avoid necrosis, or did they go for necrosis? How were the samples taken? How many slides were looked at per tumor? Was there a specific guideline? Was there a directive? And Dr. Corbin mentioned the guideline of taking one section per 2 centimeters at its longest dimension. And that's actually coming from the WHO fascicle for mesenchymal tumors, in which that is a recommendation. So that's a great starting point for us to sort of base how we would section tumors in terms of, evaluating necrosis. Again, how was the percentage estimated? Was it the highest or the average? And then, what cutoffs were used in order to interpret those results and why. So this is a possible recommendation for a scoring system that can be used for histologic necrosis. Again, this is more based on the canine soft tissue sarcoma grading scheme with 3 categories: 0 necrosis, less than 50%, and greater than 50% necrosis. So that target range of 50% seems like a pretty wide target that we'd have concordance amongst pathologists, but we still really need to assess, is this prognostic, and how much interpathologist variation is there in that assessment. We could also potentially start with smaller percentages and then maybe combine them to see, how much prognostic information we can obtain from that data. In terms of annotating necrosis, here's an example. Dr. Bertram actually took these images, and these are taken not from SlideRunner, but from the pen tool from the Aperio image software. And so what he did was outline the necrosis area in blue, sorry about that, and then outline the tumor area in green, and then divided the necrosis area into the tumor area, and he got a percentage of 10.5%. So, looking at that, we just said 10% potentially could be an important prognostic parameter. So, think to yourself, would you have called that less than 10% or greater than 10%? It's slightly higher than 10%. So, in this case, there might be a little bit of pathologist variation in how the necrosis was estimated. Here's another example. This is from a study that we did where we looked at annotating necrosis in canine soft tissue tumors. So these 2 sections were on one slide, and the goal was to estimate and then annotate necrosis within these soft tissue tumors. So just look at this slide and think to yourself, what would you estimate for this? What do you think? In increments of 10%, what do you think you would have estimated if this were a case that you were reading out? Again, we have a big hole in the sample here. Here's the annotated image from that. And so 2 pathologists measured these images, measured the necrosis, and actually obtained 2 different results. So with measuring software, one had 30 to 40% and one had 40 to 50%, but each one is less than 50%. So would you have said less than 50% or greater than 50%? This is another case that's kind of at the borderline. So, you know, how much variation is there in our estimations for these? Last one, I don't have an unannotated image of this one, but this is another soft tissue tumor where necrosis was annotated, and just, you know, look at the image and think, what would you have gotten, less than 50 or greater than 50 for this one? And this, we actually had the same results here, 30 to 40 and 40 to 50. So again, different annotations, different results, but still both less than 50%. So it can be a little bit tough for some of these tumors to get the right percentage. One other thing to think about with necrosis in tumors is that sometimes it's hard to actually even tell whether or not necrosis is there. So in the McSporran paper, again, talking about canine soft tissue sarcomas or soft tissue tumors, they say specifically in the methods that they carefully differentiated necrosis from mucinous or hyaline change. And here in the image here, we're looking at what's called hyaline change, where we have increased amounts of fibrous connective tissue in the stroma. But, you know, if you look real quick, it looks like necrosis. We have some hemorrhage in there. And so you really do have to be careful for these. Here's an image of 2 soft tissue tumors. The one on the left is the one I showed you already. The one on the right has a very similar pattern. So we have densely cellular purple areas and then less cellular pink areas. So in the image on the left, our densely cellular purple areas are viable tumor cells, and our pink areas are necrosis. If we look higher at higher magnification, we see that this is true coagulative necrosis, like Dr. Corbin showed us images of. But then if we look at this tumor on the right, these light pink areas are hyaline change. So soft tissue tumors do have a little bit of morphologic overlap between necrosis and hyaline change. Again, things like abrupt mucinous change can look like necrosis that commonly occur in soft tissue tumors. Here's a combination of mucinous and cystic change. Again, this area, if you look real quick, you know, it does look like necrosis, but if you look at the higher magnification image, you'd be really hard pressed to find a cell in which you can make out the nuclear detail. So these cells are kind of being pushed apart by edema, some hemorrhage, and some hyaline change, but it doesn't really fulfill the criteria for necrosis. Here is an image of necrosis in a soft tissue tumor, which just to show again that, you know, you really have to look closely and at high magnification for some of these tumors to be sure that that's what you're looking at. So take home points that Emily and I wanted to get across. Again, we're, you know, pretty closely following the necrosis guidelines. So, you know, when we write our methods for evaluating necrosis, whether it be gross or histologic, we should detail them appropriately so that they can be repeated by other researchers and validated, or just repeated by diagnosticians that are trying to follow the methods that we used. And then we should try to assess some interpathologist variation for, it sounds crazy, but presence or absence of necrosis, especially for soft tissue tumors. Estimation of percent necrosis. So, you know, how good are we at estimating 10 or 50%? And then, you know, it sounds like a crazy thing to say, but necrosis maybe isn't the best parameter for all tumors. Maybe it's not the best thing to include in all the grading schemes. And it kind of needs to be correlated with outcomes for lots of different tumor types, and we need to decide whether or not we should include them in our grading schemes. So that kind of segues into future considerations. Can we grossly estimate necrosis? If we do, we have to confirm with histology. If we do, we'd have to develop SOPs for technicians. We could potentially correlate it with imaging. That's another modality that could potentially be of use. We should standardize how we sample tissues, and then we can start with this WHO fascicle recommendation of 1 section per 2 centimeter diameter at the longest dimension. You know, can we standardize how we estimate necrosis? Can we use a gold standard? Is there something immunohistochemically we can use to help validate our estimates and our measurements? We've got to compare manual versus computer annotated, and then importantly, validating whether or not that 10% threshold is prognostic for canine soft tissue tumors. And then, potentially we could develop a scoring system for different tumor types, and all of these would have to be correlated with outcome in order to determine how prognostically significant they were. So here's my last slide, and this is the last presentation, I believe. So I just wanted to take a second to kind of hit home what everyone's been saying today, which is that this is an inclusive effort that we're kind of hoping that the whole vet path community will agree is needed and will embrace this. And if you do, please join us. We need a little, help in whatever way it can be provided. So, you could do something as small as letting us know when you see a mistake in a guideline or a protocol, or telling us that there was a reference we missed, to something as big as creating a new guideline or protocol. What's your favorite tumor? Come up with a protocol for it. Or performing clinical research that will help with our knowledge of these prognostic parameters. So again, this is meant to be something that's inclusive, that hopefully everyone will see a need for and contribute to, and then potentially we could make this website something that can be updated with information as it comes in and is available as an educational resource for veterinary pathologists. So here are some references. I want to acknowledge the co-authors of the necrosis guideline. Thank you for letting Emily and I speak today and reflect the work that you did on this guideline. Thank you to the Davis-Thompson Foundation and the American College of Veterinary Pathologists for sponsoring the seminar, as well as the Davis-Thompson Foundation for hosting the website. And then I think I'll stop it there for questions.
Thank you so much, Dr. Donovan and Dr. Corbin. We do have a couple of questions in the Q&A. Were you able to view those?
Let's see. Okay, with evaluation histopathologically, how do we account for the high variability in tumor necrosis among sections of the same tumor? One side will have around 50%, and then the next slide I look at has none. Some of those STS can be sneaky and some can be quite large. It's cost prohibitive to look at tons of sections. Yeah, I mean, that is very true. Again, we would expect that you would report the highest percentage of necrosis within the tissue section when you're reporting out percent necrosis, but it's never actually been documented as such. So I'd be interested to hear what people think about that. What do people do? Do they take the average or do they take the highest? I've always kind of taken the highest percentage of whatever section that I've looked at within the section. And again, we really don't have a standardized way of looking at these tumors to know how few slides we can look at to still get prognostic answers. So again, right now, I don't really have an answer for you in terms of, how many slides should be looked at, but we should at least be looking at a representative section and, being able to assess at least radial margins within those sections.
To add on to that, at the Joint Pathology Center, we use the average of all the slides that we see. And it sounds like Taryn doesn't do that. So we do, and one of our UC Davis trained pathologists also does the average. So even there's variability in what's happening right now.